Everyone, today in this video I will talk about how to approach a case of anemia. Whenever we see a patient, first thing is the patient anemic? Second thing, what is the etiology for anemia? And third thing, what is the type of anemia? Sometimes patient looks pale but not having actually anemia. So it happens when patient is having edema due to nephrotic syndrome or due to hypothyroidism. In this, pallor out of proportion to actual anemia noticed. And if the patient is having vasovagal syncope, in this condition also pallor result from cutaneous vasoconstriction. It is not a sign of anemia. And if the patient is having jaundice, cyanosis and dilatation of peripheral vessels, it may mask the pallor of anemia. So whenever we are examining the patient for the anemia, looking at the palpebral conjunctiva or palm or tongue, always keep in mind that actually anemia is here or other condition which is mimicking as the pallor. WHO cutoff values for diagnosis of anemia at different age is seen in this table. Between 6 months to 6 years, hemoglobin less than 11 gram percent we label as anemia. Between 6 years to 14 years of age, less than 12, and in adult male less than 13 gram percent, and in adult female if not pregnant then less than 12, if pregnant then less than 11 gram percent hemoglobin we label as a anemia. And for the severity of anemia, if hemoglobin is between 9 to 11, mild anemia. If it is between 7 to 9, moderate anemia. If it is less than 7, that means severe anemia. Once you are sure that patient is anemic, then second thing is what is the cause of anemia. For this you have to take the detailed history and you have to perform the physical examination to see the lymphadenopathy, hepatosplenomegaly or any sign of the bleeding is there or not, any ratios are present or not. And then you have to perform the screening test. Then according to the screening test, you have to make the probable diagnosis. Then you have to go further and perform the specific lab test to confirm the diagnosis. There are various causes of anemia. According to underlying physiology, two major categories are there. Either decreased RBC production or increased destruction or loss. So in decreased RBC production, ineffective erythropoiesis and failure of the bone marrow. These are the two things. And in increased destruction or loss, either hemolysis or sequestration or due to bleeding, patient will be anemic. So in causes of anemia, we categorize into three major categories. Either it is genetic, example thalassemia, or it may be nutritional, example iron, B12, folic acid deficiency, and sometimes even vitamin A, vitamin E deficiency. And in infections, example malaria, AIDS, tuberculosis, and some helminthic infections. So these are the three broad categories of the etiology of anemia. As I said, you have to take the detailed history. Even dietary history also give the clue what is the cause of anemia. If the child is on cow milk diet, then possibility of iron deficiency anemia will be there. If there is a history of pica, again you have to suspect the iron deficiency because pica is seen only in iron deficiency and lead poisoning. And if there is a history of goat milk diet, in this condition folate deficiency will be there, and if you perform the serum folate level then it will be less than 3 nanogram per ml. If the child is on a strict vegetarian diet, no milk product in the diet, then you have to suspect the vitamin B12 deficiency. According to physical examination, we can find the cause of anemia. In this picture, you can see the child is having massive splenomegaly. This is the case of Gaucher disease, which was admitted in our ward with the huge splenomegaly. So, if the child is having hepatosplenomegaly with lymphadenopathy, we should think leukemia. If the child is having hypertension with edema, we should think about chronic renal disease. If the child is having neurological manifestation with the anemia, we should think about B12 deficiency. If hemolytic facies are there, then hemolytic anemia. If growth failure, then anemia of chronic disease should be suspected. Child is having glossitis, angular stomatitis, barred tongue. We should suspect nutritional anemia due to deficiency of B12 folic acid or iron. If nail changes are there, spoon-shaped nail, platonychia, koilonychia, brittle nails, then we should suspect iron deficiency anemia. In this picture, you can see the child is having the hemolytic facies, large head, depressed bridge of nose, frontal bossing is there, malar prominence is there, and anterior override of maxillary teeth. So all these characteristic hemolytic facies are present when child is having hemolytic anemia. Child is having anemia with lymphadenopathy, then think leukemia, infectious mononucleosis, tuberculosis, and HIV infection. If the child is having leukemia, then hepatosplenomegaly with lymphadenopathy with anemia will be there. If infectious mononucleosis, then also lymphadenopathy ratios with anemia. If the child is having tuberculosis and HIV, then there will be a significant weight loss and other findings of this infection will also be there. If the child is having anemia with hepatosplenomegaly with fever, then think about the malaria, leukemia, disseminated tuberculosis, sepsis, infectious mononucleosis, toxoplasmosis. If not having any fever, then think about hemolytic anemia, glycogen storage disorders, Wilson disease, and leukemia. Child is having anemia with bleeding diathesis and thrombocytopenia is there, then you have to suspect the aplastic anemia, or it may be leukemia, or it may be ITP. If abnormal blood counts is there, then think about the aplastic anemia or leukemia. If the child is having history of preceding viral infection, there is no weight loss, no bone pain, no organomegaly, no lymphadenopathy with anemia, then suspect the ITP. If child is having significant bone pain, anemia out of proportion to the bleeding, and associated organomegaly and lymphadenopathy, then think about leukemia. According to the age also, we can find the cause of anemia. If the child has presented with the anemia in less than 6 month age, do not think about the nutritional anemia because it is common after the 6 month if the child was delivered full term and on breastfeeding. If the preterm delivery, child born to anemic mother and during the period of rapid growth, they are more prone to become anemic. Iron deficiency anemia generally manifests between 6 months to 3 years and during the adolescent period. Hemoglobinopathy is generally present as anemia during 6 to 18 months of age. An acute anemia at any age is due to either blood loss or due to hemolysis as seen in the G6PD deficiency, or it may be due to autoimmune hemolytic anemias. Community and family history should also be taken because it also gives the clue for the cause of anemia. Certain types of anemia occur in the particular communities. Example, G6PD deficiency common in Parsis and Sindhi. Sickle cell anemia is common in hilly and tribal communities, and thalassemia is also common in Sindhis and Punjabis. So always take the detailed history about the community and family. History of drug ingestion should also be asked because certain drug, example chloramphenicol, salicylate, NSAID causes a hypoplasia of bone marrow. Penicillin cephalosporin causes the drug-induced hemolytic anemia. Sulfur drugs, anti-malarial drugs like primaquine, quinine, mefloquine, nalidixic acid may induce the anemia in J6PD deficiency. If the child is on anticonvulsant therapy, example phenytoin, folate antagonist, it may cause the megaloblastic anemia. So always take the detailed drug history. We have to classify the anemia. There are two types of classification, either according to the underlying physiological changes and second is according to the RBC size. So according to the underlying pathophysiology, there are three categories, either due to blood loss, it may be acute or chronic. Second is due to decreased RBC production as seen in the nutritional deficiency, aplastic anemia, bone marrow infiltration like leukemia and other malignancy, also seen in this erythropoietic anemia. Third category is increased RBC destruction as seen in the hemolytic anemia, which is again divided into two subtypes, extracorpuscular and intracorpuscular. In extracorpuscular, example, isoimmune hemolytic anemia, microangiopathic anemia, or it may be due to hypersplenism. In intracorpuscular, either due to red cell membranopathy, example, spherocytosis, erythroblastopenia, another is due to hemoglobinopathy, example thalassemia, or due to RBC enzyme deficiency, example G6PD. So this is according to the underlying pathophysiology. Another classification is according to the RBC size. Anemia morphologically categorized on the basis of RBC size, mean corpuscular volume, and its microscopic appearance. Categorized into three categories: Macrocytic, Normocytic, and Macrocytic. If the size of RBC is less than 80 femtoliter, then we label as a microcytic anemia. If the size of RBC is normal between 80 to 100 femtoliter, then we label normocytic anemia. If the size of RBC is larger than 100 femtoliter, then we label as a macrocytic anemia. According to the RBC indices, we have to differentiate anemia either microcytic or normocytic or macrocytic. And second thing is we have to perform the reticulocyte count. If the reticulocyte count is low or inadequate, then there are various causes of microcytic anemia with decreased reticulocyte count. Example, iron deficiency anemia, thalassemia trait, chronic diseases or inflammation, in late poisoning, and in sideroplastic anemia, or it may be due to copper deficiency. If the microcytic anemia with increased reticulocyte count, then you have to rule out the thalassemia syndromes, hemoglobin C and E disorders, pyropyrocytosis. So after RBC indices, we have to go for reticulocyte count. And second thing is we have to calculate the RPI, reticulocyte production index. Reticulocyte production index should be calculated because it measures the magnitude of marrow production in response to hemolysis. Normal reticulocyte percentage of total RBC during childhood is approximately 1%. So if we see absolute reticulocyte count is around 25,000 to 75,000 per mmQ. And we can calculate RPI by multiplying the reticulocyte percentage with observed hematocrit upon normal hematocrit into 1 upon micro. Micro is the maturation factor of 1 to 3. Average 2, it is related to the severity of anemia. If the child is having severe anemia, then the maturation factor will be 3. If having mild anemia, then 1. If moderate, then 2. So normal RPI is 1. If it is less than 2, that means inadequate marrow response. Reticulocytopenia is there. Ineffective erythropoiesis is there. If RPI is more than 3, that means adequate response. Reticulocytosis is there. To differentiate the iron deficiency anemia from thalassemia trait, in this table you can see The RBC count will be decreased in iron deficiency anemia because of ineffective erythropoiesis, while it will be higher than normal in thalassemia trait because marrow will produce excessively in response to the hemolysis. And RDW, red cell distribution width, will be increased in iron deficiency anemia while it will be normal in thalassemia trait. And other parameters, which is specific for the iron deficiency anemia, will be altered in iron deficiency only and it will be normal in thalassemia trait. Example, serum ferritin, TIBC, transferrin saturation, FEP, transferrin receptor, reticulocyte, hemoglobin concentration, all these will be normal in thalassemia trait. Then we have to calculate the Mendzer index to differentiate the thalassemia from iron deficiency. So in this, MCV in femtoliter should be divided by RBC count in millions per microliter. If it is less than 13, that means child is having thalassemia. If it is more than 13, that means child is having iron deficiency anemia. Because we know MCV will be decreased in both, while the RBC count will be increased in thalassemia and will be decreased in iron deficiency anemia. So this is a very simple index which can be calculated just by complete blood count. So according to this, we can go further for the specific investigations. How to differentiate iron deficiency anemia from the anemia of chronic disease? Anemia of chronic disease is usually normocytic, but occasionally it may be microcytic. So in this table you can see serum ferritin will be decreased in iron deficiency while it will be normal or increase in the ACD because ferritin is an acute phase reactant. So it will be increase in the chronic inflammation or chronic diseases. TIBC will be increased in iron deficiency while it will be decreased or normal in anemia of chronic disease. Serum transferrin receptor will also be increased in iron deficiency while it will be normal in ACD. So we can differentiate by these investigations. If the MCV is decreased, then you have to go for the TIBC. If it is normal, that means child is having either anemia of chronic disease as seen in the chronic renal failure connective tissue disorders, or child may be having the congenital atransferrinemia, which is a very rare disorder. And if it is increased, that means child is having iron deficiency anemia. Now, how will you differentiate iron deficiency anemia from the lead poison? As we know, in both the anemia, MCV will be decreased and free erythrocyte protoporphyrin will be elevated in both. Coarse basophilic stippling of the RBC is prominent in lead poisoning. So in this picture you can see the basophilic stippling of the RBC is present. Then you have to go for the specific investigation for the lead poisoning in which elevated blood lead levels and urinary coproporphyrin levels will be seen, and it is specific for lead poisoning. Now, normocytic anemia. If the size of the RBC is normal between 80 to 100 femtoliter, then go for the reticulocyte count. If it is low, inadequate, then you have to think either it may be due to chronic inflammation or disease, or it may be due to RBC aplasia, example transient erythroblastopenia of childhood, or infection or drug, or it may be due to some malignancy, or it can be due to chronic renal failure or acute bleeding, or it may be due to hypersplenism, or it may be due to hemophagocytic syndrome or dyserythropoietic anemia type 2. If the count is high, reticulocyte count is high, then you have to think all the hemolytic anemia except the thalassemia in which the microcytic anemia will be there. So it may be antibody mediated hemolysis, membranopathies, enzymopathy, hemoglobinopathy, hemoglobin SS sickle cell anemia, microangiopathies, example in HUS, TTP, TIC, and hypersplenism can also be. If the child is having anemia with increased reticulocyte count and you are suspecting the hemolysis, Then go for the other indicators of accelerated erythrocyte destruction or hemolysis. So in this, with the reticulocytosis, indirect hyperbilirubinemia will be there, LDH level will be increased, and heptoglobin level will be decreased. It is a protein that binds the free hemoglobin, and fecal and urinary urobilinogen level will be increased. And when you go for the peripheral blood smear, you have to identify the abnormal RBC morphology, which is specific for specific hemolytic anemia. Transient erythroblastopenia of childhood is the most common acquired red cell aplasia in which the normocytic anemia with the decreased reticulocyte count will be seen. And this is commonly seen in the age group of 6 to 36 months of age, mostly in infancy. And we have to differentiate this from the congenital causes of red cell aplasia, example diamond Blackfan, Fanconi. It often follows the viral infection, and in this condition reticulocyte and bone marrow erythroid precursors are markedly reduced. When we go for the bone marrow aspiration or biopsy, we see the bone marrow erythroid precursor are markedly reduced. Platelets will be normal, MCV and hemoglobin F will be normal in this condition, while in diamond Blackfan, MCV will be increased and hemoglobin F will be increased. RBC ADA level will be normal in transient erythroblastopenia of childhood, while it will be increased in diamond Blackfan anemia. So we can easily differentiate by these investigation. Various abnormal shapes of the RBC poikilocytes are seen in the various nutritional or hemolytic anemias. Example, ovelocytes, in which the oval-shaped RBC are present. It is seen in the megaloblastic iron deficiency anemia and in chronic hemolytic anemia. Teardrop cells are seen in the thalassemia myelofibrosis. Target cells, in which the hemoglobin is concentrated in periphery and in center, producing the concentric dark zone. It looks like a bullseye appearance. It is seen in the thalassemia after post-splenectomy and in sideroplastic anemia. Oval-jolly bodies, these are the small, rounded, densely staining nuclear remnant. It is seen in the megaloblastic anemia after splenectomy, in iron deficiency and leukemia. Abnormal shapes of RBC in enzymopathy, example G6PD and PK deficiency. So in this picture you can see this is the bite cells, and in another you can see the hinge bodies. These are the characteristic of enzymopathy. Bite cells are also known as the stegmacytes. Is an abnormally shaped RBC with one or more semicircular portion removed from the cell margin. These bites result from the removal of denatured hemoglobin by the macrophages in the spleen. And hinge bodies, also known as hinge antlerless bodies, are the inclusion within the red blood cell. It is composed of denatured hemoglobin. It is seen in only on supravital staining. So these are the deep purple irregularly shaped small bodies in the RBCs. In hereditary spherocytosis, spherocytes are present, and shape of the spherocyte is not biconcave, instead it is round and smaller in shape and denser because MCH is more compared to the normal RBC. If spherocytes are more than 20% of total RBC, then we can say spherocytosis is there. And if we perform the osmotic fragility test, it will be positive. And then we have to perform the direct Pung test also, because not only in hereditary spherocytosis but also in other condition, example autoimmune hemolytic anemia, spherocyte can be seen. So if we perform direct Pung test, it is positive, then we have to rule out the autoimmune hemolytic anemia. If it is negative, then you have to think either hereditary spherocytosis, or it may be due to Wilson disease, or it may be due to burns, thermal injury, or clostridial septicemia. So according to the other presentation and clinical history, we have to differentiate and go for the specific test for the hereditary spherocytosis if the spherocytes are more than 20% of total RBC. In microangiopathy, example in DIC, HUS and TTP, in which the fibrin strains are generated that severs the RBC as they try to move a thrombus, and it creates the cystocyte. So in this picture you can see the helmet shaped cells also known as cystocyte, and another is horn shaped cell known as keratocyte, and these are the characteristic of normal RBCs in the microangiopathy. Now third is macrocytic anemia. If it is associated with low reticulocyte count, then think about folate and B12 deficiency, trauma, which is thiamine responsive megaloblastic anemia. Think about acquired aplastic anemia, congenital aplastic anemia as in Diamond Blackfan, Fanconi, Pearson-Mero, pancreas syndrome, and in Down syndrome, in hypothyroidism and in orotic aciduria. Macrocytic anemia with the low reticulocyte count will be there. If it is high, then think about this erythropoietic anemia 1 and 3, and sometime in active hemolysis with very elevated reticulocyte count, macrocytic RBCs will be there. When there is a macrocytic anemia, you have to differentiate, is it megaloblastic anemia due to B12 and folic acid, or it is non-megaloblastic due to other causes. So we can easily differentiate if there is a specific dietary history that patient is on goat milk diet, then we have to suspect the folate deficiency. If the child is on non-vegetarian diet, not even consuming the milk, then think about the B12 deficiency. If there is no significant dietary history, then you have to rule out the non-megaloblastic causes. If there is mucosal involvement, then think about megaloblastic. If there is systemic involvement, then think the non-megaloblastic. And if the tumors are there, then you have to suspect the NTS, nutritional tumor syndrome, or ITS, infantile tumor syndrome. And if it is not there, then other. If icterus is also present, then you have to think the megaloblastic anemia, in which the icterus is also the feature. Lab investigation to differentiate megaloblastic and non-megaloblastic. So in lab investigation, if anisocytosis is present, that means megaloblastic. If ovulocytes are also present, then think about the megaloblastic. If RDW is high, then think megaloblastic. If basophilic stippling is there, then again it is in favor of megaloblastic. Target cell will not be megaloblastic, while it will be present in some non-megaloblastic causes. If hypersegmented neutrophils are present, it is characteristic of megaloblastic. If giant platelets are present, then again it is characteristic of megaloblastic. If LDH level is high and indirect bilirubin is high, pancytopenia is associated with the megaloblastic. And when you go for the bone marrow examination, and you will find the megaloblastic changes. So all these investigations can easily differentiate megaloblastic from non-megaloblastic anemia. Now, what is trauma? It is thiamine responsive megaloblastic anemia, also known as Rosal syndrome. It is autosomal recessive. In this triad of megaloblastic anemia with the sensory neural deafness with diabetes mellitus is present, and occasionally cardiomyopathy, optic nerve atrophy, and short stature could be there. It is due to defect in thiamine responsive gene SCL19A2. It is located on chromosome 1, which encodes the plasma membrane thiamine transporter. So it is rare but always keep in mind whenever the child is having the macrocytic anemia. When the megaloblastic anemia due to B12 and folate deficiency is present, then in peripheral smear, hypersegmented neutrophils more than 5 lobes will be characteristically present. So it is suggestive of megaloblastic anemia. And you can also see the microovelocytes in this slide. Macrocytic anemia with low reticulocyte count is present and hypersegmented neutrophils are there. Then think about folate B12 deficiency and rarely orotic aciduria. If hypersegmented neutrophils are absent, then think about congenital aplastic anemia, which is maybe in diamond Blackfan, Fanconi, or Paterson-Brown-Kelly syndrome. RDW values are helpful in various diseases. So in this table you can see if the RDW is normal with low MCV, then think about thalassemia trait. If RDW high with low MCV, then think about iron deficiency anemia. If RDW is normal with high MCV, then think about aplastic anemia. If RDW is high with normal MCV, then think about chronic diseases, malignancy, myelofibrosis. If RDW and MCV both are high, then think about megaloblastic and immune hemolytic anemia. So this table is very helpful to differentiate the various causes of anemia just by the RDW and MCV. Now ask there some questions. Example, a 2 months old infant present with the anemia and MCV is normal 81 femtoliter and hemoglobin is 9 gram per dl. Then what can be the cause of anemia at this age? Is it iron deficiency or B12 deficiency or physiological or diamond Blackfan anemia? So you know in iron deficiency anemia microcytic and it's very rare in less than 6 months. And B12 it is macrocytic, so obviously this is also not the option, and again it is not common in the less than 6-month age group if the child is on breastfeeding. Now the third option is physiological of anemia. It can be the possibility. And in fourth, diamond Blackfan, it is macrocytic, not the normocytic. Answer is physiological anemia of infancy. Physiological anemia of infancy is due to hemoglobin F converts to hemoglobin A and short survival of RBC of premature infants. It is 40 to 60 days instead of 120 days, which is an adult. And at this age, in first 2-3 months, down regulation of erythropoietin is there. And this physiological anemia of infancy present in all full-term babies between the 8 to 12 weeks of age, and at this time hemoglobin will be between 9 to 11 gram per dl. And in preterm baby it is present little earlier between 3 to 6 weeks of age and hemoglobin levels between 7 to 9 gram per dl. So this is physiological anemia of infancy. Now again second question, a 3 months old infant present with severe anemia and having the triphalangeal thumb, RBC are macrocytic but no hypersegmented neutrophils are there. Reticulocytopenia is there. RBC-AD activity is increased. What will be your diagnosis? So in this macrocytic RBC, so it is not the TEC. In TEC, RBC will be normocytic, and in TEC, ADL level will be normal. So again, this is not the TEC. Now, second option is diamond Blackfan anemia. And in diamond Blackfan, I will tell you the detail RBC size will be macrocytic and the RBC ADA level will be increased. So this is probably a right answer. And what about the option C? In C option, hypersegmented neutrophils will be there and RBC-AD activity will be normal. So in this C option will be not correct. And in physiological anemia of infancy, all these things will not be there. So answer is Diamond-Blackfan anemia. So Diamond-Blackfan anemia is the congenital hypoplastic anemia. It is present in 90% cases in first years of life, especially between 2 to 6 month age, and it is congenital. It may be sporadic, sometime inherited due to mutation in DBA1 gene for ribosomal protein S19 on chromosome 19q13. And in more than 50% cases, congenital anomalies will be there. Example, short stature, craniofacial dimorphism, defect of upper extremities, including triphalangeal thumb. And for this, in investigation, you will find the macrocytic RBC, reticulocyte count will be decreased, hemoglobin F will be increased, RBC ADA level will be increased, and bone marrow will show the markedly reduced RBC precursor. Other elements are normal. Plummer-Vinson syndrome. It is also called as Paterson-Brown-Kelly syndrome or sideropenic dysphagia. It is a very rare disease. It is characterized by difficulty in swallowing, iron deficiency anemia, glossitis, cheilosis, and esophageal wave. So, if the child is having all these characteristic features, glossitis, cheilosis, esophageal wave, difficulty in swallowing with the iron deficiency anemia, you have to rule out the PVS. After doing the screening test, we have to confirm the diagnosis by confirmatory test. Example, if we are suspecting the iron deficiency anemia, then we have to go for the serum ferritin, transferrin saturation, RBC FEP levels. If the serum ferritin is less than 12 nanogram per dl, then you have to suspect the iron deficiency anemia. If we are suspecting folate deficiency, then if the serum folate level is less than 3, then we have to think about the folate deficiency and treat. If you are suspecting hereditary spherocytosis by the screening test, then you have to go for abnormal RBC cytoskeleton protein analysis using the gel electrophoresis and densitometry quantitation. If you are suspecting the thalassemia major, then you have to go for the HPLC. If you are suspecting the sickle cell anemia, then go for the sickling test. If you are suspecting the paroxysmal nocturnal hemoglobinuria, then go for the flow cytometry and acidified serum analysis test or sucrose lysis test. So, after screening, we have to confirm the diagnosis by the specific test. So, in summary, I am again telling you that whenever a patient is coming, first you have to make it clear, is it really anemic or not? Then second thing, what is the etiology behind this? And then classify it into microcytic, macrocytic or normocytic. Then go for the retic count and see reticulocyte count is normal or increased. Then after that, you have to make the probable and differential diagnosis, and after that go for specific confirmatory test whatever you are suspecting by the history and examination and the screening test. Thank you.